welcome to those of you that are here. So this is our patient education seminar on Can I Prevent Dementia? As most of you know, we've had, I think there's 7 previous ones. They are all on our YouTube channel. Amazing things about bone density, or how do I take antidepressants, sexual wellness. But tonight we have Dr. Daina Danovitch and Dr. Verna Porter, who are going to field a bunch of questions around this. When you have questions, please put them into the chat. If you see me checking my phone, I swear it's not for my kids. I'm just checking for your questions, and I'll set them up. So I'm going to let each of them introduce themselves, and we will get started. Okay, so let's start with you, Dr. Danovitch.
Sure. I'm Dr. Daina Danovitch. I grew up in the Chicago area and went to University of Illinois, then UCLA for med school. And after doing family medicine residency in New York, came back to UCLA to do my geriatrics fellowship. So I practice in Santa Monica doing both family medicine and geriatrics. And I really enjoy talking about preventive measures that people can do for their health overall.
So before we move on, Dr. Porter, can you talk about what a geriatrics fellowship is? Because I think a lot of people kind of know geriatrics, but like, what is that?
Yeah, so it's specialization in the care really of the frail elderly, so especially syndromes and conditions that are specific to older age, like dementia, fall risk, overall, deconditioning, et cetera. So, and then a lot of emphasis on working with patients who have complex and sometimes conflicting medical conditions and medications. So lots of emphasis on getting to know medications well and
other specialties.
Interactions. Yeah.
And when does someone enter?
No.
I don't even want to ask.
Yeah, no.
But when does someone enter geriatrics?
Yeah, I get that question a lot. So there's not a specific number. It's not like once you qualify for AARP, you're geriatric or something. So
I already got the card.
Yeah, I know. So really, it's. I'd say some patients come to me already because they want to set themselves up to have somebody who knows them before they become frail. And then otherwise, I'd say really truly geriatric patients are those who are really starting to feel overwhelmed with medical conditions and medications.
Okay.
And often they or their family are seeking out somebody who's more comfortable in that zone and how to kind of optimize their quality of life and their health now that they're in that phase where those things are more burdensome. So it's often more in the 80s and 90s, and in Santa Monica, 80 is the new 60. And so it's
exactly.
It's not really number specific. It's more once people are starting to feel like their health is kind of declining.
Okay.
With more age-related conditions.
Great. Dr. Porter?
All right, so I'm Dr. Verna Porter, and I'm Director of Alzheimer's and Neurocognitive Programs at Pacific Neuroscience Institute, so that's part of Providence. And I also did my medical training at UCLA, so I did all of my training basically there. I am dual fellowship trained actually in geriatric medicine, but also in neurology and neurobehavior and neurocognitive programs. So I have a little bit of background in neuropsychiatry, but also neurodegenerative disease. We're talking about Alzheimer's and various other things, which I'm sure we'll touch on today. And I also take care of patients who are older. Generally, I would say 65 and older is kind of my patient population. And I see folks who are experiencing memory and cognitive change.
Amazing. We're so excited to have you guys. So I have a bunch of questions that have come in from patients or some of the other physicians who gave me questions, but please feel free to put things in the chat. I will be monitoring it as we go, but I feel like a really good place to start is what is dementia? And I know there's a couple of different kinds, so who wants to start with that? Do you want to start, and then we'll have
Sure.
Dr. Danovitch?
I send a lot of my patients for neurocognitive testing. And so when they see like a neuropsychologist and they get evaluated, I always try to explain it as we're comparing you to your peers. So you versus other people your age, your educational level, how do you compare to that group? And so when people do that sort of testing, they tend to fall into one of three basic categories. Either they're normal for age, so normal, typical, as expected, or they have something called mild cognitive impairment, which is beyond the normal range, but mildly so. But they're still very functional. They're able to drive and shop and cook and clean and manage their daily affairs, often work, without a lot of impairment. And then the third category is dementia. That's where there are more notable, more concerning problems. And it's not just memory. It could be visual spatial problems, language-based problems, behavioral problems, but it's to the point where it's beginning to interfere with daily activities and functions. And so it's really on a continuum in a sense. And so obviously a person could start with normal cognitive functioning, progress into mild cognitive impairment, and then end up with dementia. And then there's stages of dementia as well. So it's a general term. It's not a diagnosis unto itself in a sense. So it's not like saying Alzheimer's disease, which is a diagnosis. It's more of a descriptor of how you compare to your peer group.
So Dr. Danovitch, in that same light, and you can expand on it a little bit, but how do you decide when someone is when you tell their family members you might be suffering from dementia?
Can you clarify your question?
So how do you decide when someone has dementia?
Yeah, so first I'd say I don't really decide in one visit, because anybody can have a bad day, and that's really, yeah. And, you know, as part of our wellness visits with patients over 65 now, we standardly will ask them to remember 3 items and draw a clock. And that's a short little screener that we can do to check on their thinking. And a lot of times people are really nervous because maybe they haven't thought about a clock in a while. Maybe they're also thinking about their dinner.
I just look at my iPhone.
Yeah. But sometimes people bomb that test and they're so worried.
Okay.
And I just try to reassure people, hey, you know, anybody can have a bad day. We're not going to make any diagnoses here.
Right.
But I will usually ask them to come back and do a little more testing with me, start to talk to them a little bit more to get a sense of whether this actually might be reflecting some difficulties that they've been having. I'll invite them if they want to bring family in, if they have been having trouble, so that they can share what they've been seeing as well. So sometimes people don't know what they don't know, right?
Yeah.
So I would say, you know, we don't jump to a diagnosis by any stretch, because it has a lot of weight to it when you use that word. So usually I'll just talk to people and say, it seems like you're having more difficulty with your memory, or some of this, you know, this task seems difficult for you. Have other things been difficult? And we'll sort of start the conversation there. And sometimes, you know, once we do get family and the patient in, it may be that things are already pretty advanced and clear. But sometimes it's not as clear, and then actually we'll often ask patients to see someone like Dr. Porter to get more testing done and clarify if somebody's very early and we're trying to figure out what's going on.
So a quick question about that, because, you know, one of the things that we see is how difficult this is in a family dynamic, right? So when you do refer to someone like Dr. Porter, do you get pushback?
Sometimes. Sometimes people are begging for more answers and want to go. And that's often coming from family who've been seeing things and are worried and want to make sure that they know what's going on and can start preparing and figuring out how to support their family member or their loved one. But patients are often really afraid to be labeled. They're afraid to kind of have anybody look too much under the hood, you know? So, you know, we don't force anybody to do anything, but we really try to help people understand that knowledge is power. The more we know and the sooner we know it, the more we can figure out how to support you, how to get, you know, things lined up around you to make sure you're safe, and the more you can be involved in making any decisions that are related to your care. So usually we get there, but sometimes it takes some time for patients to start to accept it. Yeah.
And Dr. Porter, where do you think most of your referrals come from, like percentage-wise?
That's interesting. I'd say a lot come referred from a primary care physician.
Okay.
Some come self-referred. Some come from other specialists, like, I even have referrals from OBGYNs and things like that in the context of women's health care. So it really depends. And sometimes a family member will actually encourage it as well. So that ancillary historian, that other person who knows the person well, the patient well, that's often the person who will initiate it.
Okay. So obviously the topic of this discussion is, can I prevent dementia? So I'd like to have each of you just talk about a few. I mean, I know there's a bunch of research and different things that we talk about, but can you guys kind of go back and forth and share a couple of important elements of what we can all do to slow the onslaught?
Well, I think I always start talking with patients about what's good for your heart is ultimately good for your brain. And what I mean by that is, good diet and exercise and nutritional practices and minimizing vascular risk, making sure your blood pressure is under good control, your blood sugars, your cholesterol panels, all of that's very important. So if you're doing things that are good for your vascular system, ultimately it's going to benefit your brain as well. And we know that patients who have more vascular problems tend to be more predisposed to getting neurodegenerative conditions like Alzheimer's, like other forms of dementia. So if we can be preventative in that sense, that's a big win. And then I always talk about three basic things. Socialization, being social, being active, being engaged with other people, tremendously important to the brain. Cardiovascular risk, trying to minimize that, like we just touched on, blood pressure, cholesterol, blood sugars. Sleep apnea, that's a big one that's often overlooked. That is a vascular risk factor. That increases risk for dementia. So that all falls under prevention. And then exercise, really important. Exercise is a big one. It increases, brain-derived neurotrophic factor. It increases kind of cognitive health and well-being. It diminishes stress. It lowers cortisol. It does a variety of things that are proactive and beneficial for the body and the brain. So if you can work on those three things, socialization, reducing cognitive risk factors, exercise, that's a big part of prevention right there.
And we've talked about doing exercise with social interaction, kind of capitalizes on both because your brain's working while your heart is working.
Yes,
and that
it's called dual tasking, absolutely.
Dual tasking, yeah.
Yes, we have a cognitive fitness gym that does that sort of thing.
Yes.
As part of our built-out program at Pacific Brain Health Center. So that's something very unique that we offer our patients.
It is unique. I've tried it a couple times. It's good.
Yeah.
Dr. Danovitch?
Yeah, I think there's different things people can do at different stages.
Yes.
So just like with other parts of our body, first you want to start with the healthiest specimen that you can. So, building a dense network of connections in your brain. We've seen in studies that it's actually protective when people have done advanced degrees, learned multiple languages, etc. So one of the things is, very early on is pushing your brain to get as loaded up with connections as you can, protecting your brain, so helmets.
When you say very early on, what are you talking about?
I'm talking about 20s, 30s, 40s.
Okay.
I mean, people already are asking me, how to keep their brain healthy. So that's one thing. And, you don't necessarily choose to go to college to prevent dementia, but there are protective factors to being really active with your brain. A big thing, I echo what you're saying, is physical activity is so, so important. The same circulation that runs through your heart runs through your brain. And so I really spend a lot of time in that. That's for prevention of dementia for so many illnesses. It makes such a difference. The movers of the world end up healthier at the other end of things, barring dysfortune, genetics, other things. But if you can be a consistent mover day in and day out, not just going to exercise classes, but taking breaks from your computer to walk regularly, hitting some step targets, even if it's a day that you're not making it to the gym, the people who are movers end up healthier at the end of the road. So that's something I really emphasize with patients, especially a lot of, on the family medicine side of my practice, I have a lot of working moms, people are juggling a lot, and I really just encourage them that, the taking care of yourself now matters. Blood pressure control, even in midlife, is super important for protecting the brain. So we, even though people don't want to think about upping their medication in their 40s or their 50s to make sure their, blood pressure is running under 120, it's worth it. So it's something we work with. And then I would say also avoiding kind of drags on the brain. So, sleeping medications, especially as I work with my older patients, a lot of people have to be on medications to control bladder symptoms, for example, or they're taking older antidepressants that can have negative effects on the brain. So not the more typical ones like Prozac and sertraline, Zoloft, the SSRIs, those are safe. But old ones like amitriptyline, some people are still using those for sleep, and those have been shown to increase the risk of dementia. So we look over kind of how people are caring for themselves and also just try to clean up any junk that might slow the brain down.
So blood pressure is an interesting one because patients who have high blood pressure will say, I feel fine. Yeah. It's a little high, but I don't really want to take the medication. Can you just talk a little bit about the pathophysiology of that and how it impacts the brain? Or you guys can share it.
Yeah, brain pathophys might go to the neurologist, but I'll say just to clarify, I wouldn't put someone on medication, who has a blood pressure of 125, right?
No, but if they're
regularly, when I see people in for their physical and the pressure's in their 130, I'll say, hey, you're starting to push it. You might want to, dial back on the salt, look at your exercise routine,
right.
See if you can trim down a little. Let's see if we can make some lifestyle changes to keep this pressure low. And there are real reasons to do it.
And I think we already sort of touched on the notion that vascular health and brain health, it sort of is intimately tied together. And those smallest, most penetrating blood vessels, the capillaries in the brain, are very sensitive to fluctuations in blood pressure. And you can imagine if you have kind of like a hose and it's not particularly strong or well built, and you just blast pressure through it, over a while it's going to kind of give way and it's going to start to leak, or there's going to be a variety of problems in the flow. Kind of is the same thing in the brain. So you don't want to be harming your vascular system. And keeping the blood pressure in the normal range is really important to being able to kind of maintain the integrity of those small penetrating blood vessels, which lead to small vessel disease if they're not well attended to. And that increases the risk for stroke, and that can be a mini stroke, it could be a more major stroke. So it's a definite leading indication of this is a problem that you need to attend to when you're young so that you don't end up with strokes and problems as you age.
Because it's just a chronic, blasting it, right?
Yeah.
So it is important, even if you feel well, to maintain blood pressure.
Absolutely. I think there's also, unfortunately, a strong association between high blood pressure and other associated vascular risk factors too. So it's not at all uncommon that a person has not only high blood pressure, but maybe high cholesterol. And maybe their blood sugars are running a little bit high. And inactivity increases the risk for hypertension. So if they're inactive, they may be a little heavier. They may be more predisposed to sleep apnea or other problems. Again, another vascular risk factor. Yeah. So looking at kind of the inner associations of those things is really important too.
Yeah, that's the other one when people have a little high blood glucose or a little high hemoglobin A1C, and they're like, but I feel fine. And it's like, but we really need to keep that down for all of these long-term impacts. So Dr. Danovitch, you talked about exercise, and I don't even know where this comes from. It might be 15 years old, but it was 20 minutes of cardio 3 times a day. Is that still what is the recommendation now? You kind of use movement and steps. Is there cardio? What is the recommendation now from a primary care
Well,
standpoint?
I think it depends what you're paying attention to. I think the studies for dementia prevention showed the best with 150 minutes per week, moderate to vigorous exercise. So that's sort of the number. So what does that come out to?
And
that's
how many people meet
right?
that? It is a lot.
It's kind of a lot. And so this is what I'm saying. I like to meet people where they're at.
Yeah.
And I think a lot of people, when they feel like they can't reach it, they're just, why start, right? And so I really work with people to say, look, if you're sitting on the side of the playground watching your kid play, start walking laps around them.
Yeah.
Or
You're there.
talk to another parent at the playground and say, how about you cover them while I go do a jog? And just start wherever you're at. If you can't make it to the gym, you can't make it to something, you start where it's at. So, as much as that's the ideal and that was studied, there's also been, other studies that showed, so, the 150 minutes has the strongest evidence behind it, but there's been nice studies. Dementia is a little bit hard to study because it's so far down the line, but when they've looked at larger populations to see who's the healthiest and then looked back at their patterns, they can see about 50% less dementia in people who were consistently moving 8,000 to 10,000 steps a day. So is that an exact causal thing? No, but it kind of says the movers seem to get less of this. And what was nice in the studies where they really kind of tried to parse it out, they saw that, okay, maybe if you're the 8,000 to 10,000 step range, you get the most benefit. But at the 6,000 step range, you also are doing way better than the people who are under 3,000 steps, right?
Right.
And so there really was not exactly a linear dose thing, but there were benefits wherever you were at. So, I just encourage people to
do a little more,
do a little more, and try to do a little more, whatever you can do for now. And the reason I like steps, and is because you can gamify it a little, and
Sure.
you can communicate in the family about it too. So
and your phone just keeps track of it. Like
your phone keeps track of it. You can wear
have the
something,
fancy watch or the ring,
and you can kind of set goals within the family to say, hey, like with your partner, you can say, let's try not to let the sun go down on less than 5,000 steps a day. So if you're finishing work and you only had 1,000, you can say, hey, can you watch the kids while we go for a walk, or let me just go do something. So I think, it's not perfect, and I think, there are health optimizers out there who don't love the steps, but I just find it to be sort of a manageable thing to think about, that you can kind of feel good if you're making some progress.
And it adds the social aspect, which is if you go with someone else, you can talk and get the other cognitive benefits.
Absolutely. I think a good rule of thumb, people often ask me, like, what do you mean by moderately aerobic exercise? And I always tell them, if you're walking with a partner and you're not winded at all, that's not moderate. Your heart rate needs to be up a little bit. You need to be slightly winded. That gives you a sense of what we mean by moderately aerobic exercise. So if you can hit that kind of target, that's what we want to see. That's the most beneficial for the brain, particularly in terms of like prevention of cognitive decline as you age.
That's great. So something that neither of you mentioned, but I know we've talked about, is sleep and how that plays into this. So I know you both have things to say on this. Who wants to start?
I'm happy to start.
Okay, go ahead.
So, sleep is a really interesting time. We spend so much of our lives in sleep, but a lot of things happen during sleep that I think people don't fully appreciate. Sleep is a time when your brain clears toxins out of its system. It sort of flushes in a sense. And amyloid, which is an abnormal protein that builds up in the context of Alzheimer's disease, it's one of our sort of physical signs of Alzheimer's is you get this deposition of amyloid in the brain. Amyloid is something we all have in our brains as we age to a certain degree, but you will flush it out of the brain through a very physiologic, very normal process in the context of adequate sleep. If you go through the traditional steps of sleep, there are certain stages in sleep, and REM is the rapid eye movement phase. That's the deepest phase of sleep, and you have to kind of go through these cycles during the night in a certain repetitive fashion to get, quote, good sleep. But if you're able to do that, the brain is able to do what it needs to do in flushing these abnormal toxins out of the brain and also restoring itself. We deposit memories during sleep. So things are transferred from your short-term memory into your long-term memory through the hippocampus, which is an important memory circuit in the brain. Cortisol regulation happens during sleep, so that's kind of our stress hormone. And the stress hormone, when it's high, it abnormally affects the hippocampus, that memory circuit, transferring short to long-term memory. So sleep is really important. And if you're not getting oxygen when you sleep, like with sleep apnea, big problem. If you're not sleeping well because your sleep is constantly disrupted because of musculoskeletal pain or discomfort, that's a problem too. So you want to be able to do everything you can to optimize sleep, keeping the room lights low, keeping your stress levels low, having set patterns to your sleep, because the more regulated your sleep is, the better the brain's going to like it, and the more the brain can go through its patterns and functions more normally.
Okay. You don't see anyone with sleep problems, right?
Okay.
Not at all.
Everyone's sleeping very normally.
Yeah. No, I think sleep, it really is crucial. And I think especially with screens now, sometimes people are just running sleep deficits by choice, essentially, you know, and then also people work so hard. People are taking emails late at night, getting up early for East Coast hours. I mean, so I think starting early to make sleep a priority is probably really important. And then I just would add, you know, sometimes people say, well, I know sleep is really important. It's hard for me to sleep. Doesn't it make sense just to take a sleeping pill then? And unfortunately, no. I mean, I think having a sleeping pill occasionally for, you know, travel, whatever, when people are jet lagged or something like this is one thing. But, you know, using a sleeping pill regularly for sleep typically doesn't create the same sleep architecture that you need to really restore things. And then some of the sleeping pills have also been implicated in having some negative effects on the brain, you know, long term as well. So you really got to kind of do the work to clean up your sleep yourself as much as possible. And then I absolutely agree that getting sleep apnea diagnosed and treated, even though nobody loves thinking about getting CPAP, there are other treatments as well. And it is so common now that I really just try to normalize that for people and encourage them to find out if they have sleep apnea and absolutely treat it, because it is so important to get restorative sleep.
So on that, I know you used to have to like go to a center and take your pillow. There used to be one down here and people would show up all the time. But there's other ways now to test for sleep apnea that you can just do at home, right?
Yeah. The primary care doctor can order a home sleep test.
Okay.
And that, I mean, it's much easier. You do it at home, you wear some devices at home for a night or two, and it gets pretty good information. So that's really lowered the bar and got a lot more people testing and finding out that they have it.
So 2 questions along with sleep, even though it's not what it's about, but obviously it has a big impact. So you said there were other tests, and are you the person who is a primary care doctor, the one you should go to if you have sleep apnea, or are there sleep specialists?
There are sleep specialists. I think I said there are other treatments. So CPAP, there's also a nasal.
CPAP is the one everyone thinks is so awful.
Yeah, with the mask or the thing, but it works. And, you know, I certainly have patients who were fighting it, and then they used it and they woke up and they were like, oh my gosh.
My life has changed.
My life has changed. I just introduced my girlfriend to the machine and then so be it, because I am not sleeping without it. But there are other treatments. There's these nasal kind of pillows called bongos. There's mouth devices. Yeah. So they're not appropriate for everyone, but I just like, you know, people are like, well, I know I'm not going to treat it, so I'm not even going to test. I encourage people to just kind of get over that and see what's
and mention
going
it to their primary care doctor when they go.
Yeah.
Or usually it's the partner.
The primary care doctor can refer you for a sleep study, but at least in my practice, if somebody needs treatment, I have them see a sleep specialist, because they really understand the ins and outs of all the equipment and getting people set up so that it's as comfortable as it can be and is kind of user-friendly.
Great.
But I will say, just on the sleep apnea note, there's a misconception that people have that people think that they would be aware of it. They say, no, I sleep great. I fall asleep great. I sleep all night. And if they're sleeping on their own, I just want to make sure people know they may really not know that they have sleep apnea, because you're not conscious of the sleep disordered breathing, the pauses in breathing, the sort of semi-wake-ups that are happening. So people really are shocked when they get the results back, and it can show even
And they're never
apnea.
getting into deep sleep because they just keep waking up.
And they can have low oxygen levels even at night.
And also, snoring is not an absolute indication of sleep apnea or not. So you can not snore at all and still have sleep apnea. So that's kind of a misconception
Or you
that's
can
out there.
snore and be sleeping just fine, except for your partner's
so
not.
snoring itself does not equate to sleep apnea and the other way around. So it is important to kind of think about, just getting screened at some point in time. It makes sense for a lot of people, like probably, frankly, over the age of about 55 to get that screening, but particularly get it if you're noticing memory or cognitive change, because it could be a driving factor for that. And untreated sleep apnea, it's not only increasing your cardiovascular risk, so, heart problems, atrial fibrillation, various things, but cerebral vascular disease is worsened, and it increases the risk for dementia notably. So it's kind of a all-comers in terms of what it may do to the body. It's important, very important.
Get it treated. It's a fountain of youth.
So we're going to go on to genetics, but there's a question which is, and this question is specifically about herbal teas to help you sleep, but I know you talked about some of the pharmacologic pills. Are there things like melatonin and herbal teas, or are those things fine to use for sleep?
Most things for sleep are fine to use sometimes. That's really the
if you're using it every night.
Yeah, then it can be a problem. But, having some chamomile tea, having a warm milk, anything like that, sometimes that can be part of somebody's, sleep routine
Ritual,
to help them, kind of engage all their senses and realizing that now it's bedtime, turning the lights down, smelling their tea, brewing, that can be very positive.
And does a sleep specialist help outside of just sleep apnea, but with these kind of things?
Yeah.
If
some of them can do cognitive behavioral therapy for insomnia, which is, by the way, the best way to treat people who have chronic insomnia. Can go through a course of cognitive behavioral therapy to really kind of retrain their sleep.
And it can be very effective. Yeah. So without the use of medications.
Awesome. So someone whose parent had dementia at 80, are they at higher risk for dementia themselves?
So the answer is not necessarily. I think it's important to realize that the majority of cases of Alzheimer's are actually not familial, or at least not attributable to genes that we yet know how to test for. I think that's a good way to say it, is that there may be many genes that are yet to be defined and evaluated for in a clinical setting that may be relevant for Alzheimer's risk. But in terms of common things that we tend to think of or test for, like ApoE4 gene, that's something that's associated with late onset, meaning over the age of 65, Alzheimer's disease. But that is a minority of cases of Alzheimer's disease, not the majority. So it is something where you have to think about, is there a family history? Would it be meaningful to test for this? That particular gene also has implications nowadays for use of very new medications for Alzheimer's, infusional monoclonal anti-amyloid antibodies, and we can touch on that if people are interested, but these are kind of very new infusional drugs that are being used to try to rid the brain of amyloid. But unfortunately, people are at higher risk for side effects from those drugs if they have the ApoE4 gene. So it's becoming a more relevant piece of data to know in the context of decision making for particular treatment options.
Do you have anything to add to that? Just around, how do you talk to patients?
I generally say, for most things, I worry most when there are conditions that are happening early or often in a family. So if somebody could describe that maybe mom had dementia at 80, but 3 of her sisters also had dementia at 70 and 65, then, you start to think maybe something's going on in that family. Or if somebody had an earlier onset, that's different. So I would say that's how I think about it. But we do know that lifestyle does make a difference, and that people who live to advanced age can show. And remember, dementia, if somebody says, my grandfather had dementia, we don't know from that history whether it was Alzheimer's or whether a very common one is vascular, right? So maybe this is the grandfather who also had diabetes and blood pressure or didn't like to go to the doctor or exercise, and his brain was just under pressure his whole life.
Retired at 55 and
and so there he is now at 80 and things aren't working so well. So that may not be passed on to you or your siblings if you're really living very differently. So I don't put too much stock in it if someone has one relative with something at an advanced stage.
And I think it's really important to realize that, you know, genes are genes, we can't change that, but epigenetics is a whole new area of interest in research, and just the understanding that we do have some ability to modulate gene expression that's under our control as individuals, like choices about exercise and diet and sleep, and all these things we've been touching on do influence and impact whether genes turn on or they stay off. So there are ways to kind of mitigate risk even if you know you have a genetic risk factor.
So I'm going to ask you this question first, Dr. Danovitch, and then we'll go to Dr. Porter. So a patient comes to you and they say, my parent has Alzheimer's, dementia, I want to start on the meds now.
Oh, like Namenda and Aricept?
I don't know what they are, you know what they are, but
And-
yes.
yeah.
So how do you answer that question? You can't say, I just refer them to Dr. Porter.
They don't work. They don't work to prevent dementia. That's really the short and long of it.
Oh, none of them?
None of them, unfortunately, are preventative. That's absolutely correct.
See, I've been
to say
listening to
that.
the radio too much. I'm not taking them, but
So
I'm
the
listening to the radio too much.
The most preventative thing out there for preventing dementia, the number one, is actually exercise. Isn't that ironic? So the very thing that we don't pay for, we don't have to buy, you don't have to take it in a pill, that is actually probably the most effective anti-aging and kind of anti-dementia drug, as it were, that's out there. But yes, drugs like Aricept, Namenda, Razodine, Exelon, all these kind of old tried and true drugs that have been on market for decades. These are drugs that modulate kind of neurochemicals in the brain. They can either increase or decrease or modulate in various ways different neurotransmitters. So they help nerves talk one to the other, kind of like a telephone wire. But they fundamentally don't get at the underlying root problem at all, which is oftentimes theoretically amyloid deposition or tau deposition or other things. We don't know what triggers that. We don't know exactly what sets that off. And so it has no effect on that whatsoever. So these are symptomatic drugs. They slow the rate of progression. They put the brakes on. They slow the rate of progression of how quickly things evolve, but they don't stop it, and they don't fix it or cure it or reverse it, and they don't eliminate the possibility of getting it preventatively. So that's an important thing to know. So just taking those drugs, and remember, all drugs have side effects and problems and issues. Just taking a drug for the sole purpose of trying to prevent something on down the line, that won't work, unfortunately, with these drugs.
Will one of these apps that you're like supposed to be finding things, do those work?
What is it?
You know, like the ones that are supposed to test your mind, the apps that you can download where you're finding words or you're putting different puzzles together.
Oh, like Wordling or something?
Yes.
I mean, keeping your
those are
brain
not-
active is important, but
None of those are like, you know, FDA approved diagnostic tests. That being said,
It's a little like CogFit, but you're not doing the physical part, right?
I think we're obviously making very subjective impressions about whether somebody's experiencing change. So if you notice that you've been doing this game for months and all of a sudden your scores start dropping and you're worried that you're not as efficient, well, that's kind of a warning sign, clearly. But I think in terms of, you know, is that like a diagnostic test for it? No, it wouldn't be an appropriate diagnostic test. But I think you may begin to see changes. Yeah, you may begin to see changes in how your brain functions. And that's the first sign where you want to get in and see a doctor. You know, probably start with your primary doctor, get an assessment, get an evaluation. They have tools at their fingertips for doing good screens. And then if those come back positive, meaning there's an increased risk or chance of a concern, then going on and having a more comprehensive evaluation makes sense. But I think the flip question is like, are those things good? Like, can you prevent dementia by just doing Sudoku or doing things on your phone?
Please say yes.
Well, here's the honest answer. It's helpful. Anything you do to stimulate your brain is cognitively helpful. But what your brain really thrives on is novelty. Your brain wants you to do different things, and it's very, very stimulated, interestingly, by social interaction. The very thing that as a society we're diminishing dramatically, kind of generation to generation. So all the screen time and all the kind of time on our phones and these solitary activities, although they may have some benefit, they're not nearly as beneficial as doing things like learning a new language in a group setting or going to a book club or things like that that are more interactive. So the brain, again, thrives on kind of that multimodality stimulation, not just one thing the same way every day, but different things, different ways, with different people in different settings and different groups, that's what your brain wants. So the phone is not the answer.
Even if the introverted he doesn't?
You mentioned something that I just wanted to touch on. If people do notice that there's been a change, I think we didn't mention that sometimes there are non-dementia things that can be affecting your brain and that can be identified. So, if people are noticing that they are slower with tasks than they were before, or they're forgetting things, starting with the primary care doctor to at least be able to check if the thyroid is in range, the B12 is in range, sleep also we look at. So there are other things we look at I've had patients come in who were confused because their sodium was really out of range. So getting some basic evaluation to look at their overall health is an important first step. So
And you're talking about basic,
assume,
meaning what your primary care doctor could do, not one of these like giant panels.
Correct.
Where some people.
No, right. We're looking for reversible causes. We look at their meds too. Sometimes we find out somebody has been using Tylenol PM every night to sleep. And, for older adults, that can start to really put a drag on the system, and they will start to really have poor memory for the things that happened the night before, et cetera. So, it's really important to start and keep an open mind, not be afraid to bring it up with your doctor, so that we can look to see if there's things that are reversible that we need to clean up.
So we've talked a little bit about the pharmacologic, medicines. What about diet? How does diet impact your trajectory to dementia?
Diet's really important. Just aside, I also want to say mood-related concerns like depression, anxiety, those sorts of things can really color and affect cognitive functioning too. I mean, there's a term, pseudo-dementia. It can look like you have dementia simply because of depression. So that's another really important thing the primary doctor or neurologist or a variety of people could evaluate and assess for that. So we don't want to lose track of things like that as causative factors for cognitive or memory change, and simply jump to the conclusion, it must be Alzheimer's. That's quite a leap of faith in a sense, because there's so many things that it could be that might be modulated or affected or fully treated and reversed. So you always want to look for that. On diet, diet is extremely important. So to me, the number one most important thing about diet is it achievable? Is it attainable, and can you maintain it? Because the best diets in the world, if they're not maintainable, they're not worth anything. So, for example, the ketogenic diet, it's a very good kind of anti-dementia type diet. It is very difficult to fastidiously maintain a ketogenic diet in its true and honest sense. So there are some good diets out there that have positive benefit, but again, they're very hard. So a very realistic diet that I like to give my patients is the MIND diet. It's like a modified Mediterranean type diet. There are whole cookbooks written on this. And it's, lots of fresh fruits and legumes and low on red meats and high on poultry and things like that, and whole grains, and very, very low on anything that's processed, little to no processed food. And you don't want artificial sweeteners and that sort of thing. So that's a good example of a diet that I think is very achievable and attainable and something you can maintain long term. So that's the kind of thing that I would tend to guide towards.
I would agree with that, and I'd say I more often really emphasize the Mediterranean diet since I'm working with people across different conditions.
It's a little easier for.
Yeah, and to me it's such a beautiful way to eat with great fruits and vegetables and olive oil, and so I think it's a non-depressing diet, which is, like you said, attainable and sustainable. So. I think people can modify it to be vegetarian or vegan if they prefer, and that. And what did I want to add? Oh, just one other thing that coming back to when we were talking about coming in and catching things that might look like dementia. Another big one is hearing loss.
Oh, yeah,
Huge.
that's good.
Huge. Sometimes people are shocked when their parent finally gets those hearing aids and they are engaged and present and responding and remembering. People can sometimes start to sort of fade into the background who aren't hearing
If they're
well.
not hearing.
So A, it can look like dementia, and B, if you don't have good hearing and you're starting to socially withdraw, you're not as engaged in everything, you're not using your brain the way you need to. So I definitely encourage anybody to pursue, hearing aids if they need them. Don't fear it. Optimize your senses. It's one of the best things you can do for your brain.
Yeah, I think that's huge. Dr. Volker gave a great lecture on that. So if somebody does, we all tell our partners, do you not hear me? But where do you start with that? Do you go to like a hearing center? Do you go to your primary care doctor? Like where do you start with that if somebody wants to get that checked?
So, of course, your primary care doctor can refer you to local audiology centers.
Okay, fine.
But Costco does great hearing tests.
Oh.
A lot of my patients have already done it at Costco. So, yeah, it doesn't have to be, complicated.
I do have a question. Well, I have a couple of questions. But so how can you tell what normal forgetfulness is? You guys kind of touched on this, but we all you tell your partner to do something, they forget. You're like, dude, how could you not do that? So what's normal forgetfulness, or when do you start to have concern?
For example, you occasionally misplace your keys, you misplace your glasses, maybe you put things in an odd location once in a while, or you walk into a room and you forget your intent, upon entering the room. That's not terribly unusual as part of normal aging. But it's really when it begins to be more of a pattern, something that's beginning to interfere with your ability to kind of carry on your daily activities and chores, like, oh my gosh, I forgot my glasses for the 4th time this week. That's a little concerning. That's something where you want to have a little bit of a red flag and say, that's a little bit beyond what you'd like to normally see. And I think we all have a sense as we, in the 40s and 50s, of occasionally you might forget things here and there.
And you're like, oh no, is this it?
Yeah, but if it gets to be much more or dramatically different than what you've kind of historically experienced, then any sort of change in your own mood and behavior and all these different things we've been touching on would be sort of that red flag to get it checked out. So you want to be seen and evaluated if you're noticing that you are more forgetful, or your spouse or your significant other is always reminding you about various things, or having to bring things up again and again, or have to be reminded about appointments or dates or events or upcoming things. Those are all kind of little bit of red flags. And again, going to your primary doctor, getting a good basic screening assessment is a really good idea, probably by the time you're about 50. That's when those sorts of evaluations start.
Do you have patients keep journals of what their spouse is forgetting or when they're forgetting? What do you do when somebody's like, I forgot my glasses 3 times?
I think the specifics matter. So I think with how distracted people are and multitasking, I think it's huge. It's huge. So maybe you did tell your partner, but they were on their phone doing something, or so the multitasking and the sort of the way our brains are working right now is different. And so I do try to reassure people when it's just, I forgot a name, I forgot this or that, because if it came to you moments later, usually that means it got in, but maybe you needed more clues, more tickling to pull it out. I would say when I have older adults who are really getting worried, we'll do some of the testing, and if they, let's say, can't get the word right away, but just with a little bit of a clue, it's all right there, that's a little reassuring to me. That tells me that they are filing things in, but they're needing a little more to get it out of there. It was on the tip of their tongue, but now it's coming out. So I think there's sort of gradations that we can try to help people navigate, but I do, I will say, people are coming in their 20s thinking that they have memory problems, and I'm like, maybe take
you left your keys at the bar?
Unplug. Yeah, right. Attention matters.
So there's another question that came in. So you talked about the screening that you just do every year as people age, which is, draw a clock, remember 3 things. Is there more advanced screening that you do when somebody has serious concerns? It says, what's the screening consist of from your internist? Is that the best place to start, is the question.
Yeah, I'd say the two most common tests that the primary care doctors will do if there is some concern would be the MoCA, Montreal Cognitive Assessment, and then the mini mental status exam. So those are both more, instead of just like 2 items, it's, you know, a score of 30 that you can get. Takes maybe 10 to 15 minutes to do.
And it's a paper, you give it to them on paper, or?
No, it's mostly verbal.
Okay.
You know, there's some stuff that they draw, but it's mostly done verbally. So we usually do it as a separate appointment so they can just relax. I usually ask their family to get out of the room so they're not anxious while, you know, feeling like if they make a mistake, someone's watching. And we just, you know, kind of muddle through it, and then I can give them some feedback. Okay, this stuff looks easy. This stuff looks, you know, really hard. And then there are also some follow-up tests I can do, but usually if their scoring is looking pretty rough on that, then we're going to think about referring for more advanced testing with a neuropsychologist where they can really sit down and spend, you know, hours making, really kind of picking apart what's working and what's not.
And Dr. Porter, we had talked about it, you know, one point, because there's, you know, so many women coming through the Institute, doing a study where you could just every year give somebody, is this one of these like MoCA tests, or would something like that, like what do you do? What's your assessment?
I do the MoCA, so
Okay.
that's the Montreal Cognitive Assessment.
Okay.
This is a very standardized testing battery, again, 30 points, but it kind of systematically covers different areas of cognitive functioning. So there's like a 5-item memory task, for example, but there's also kind of visual spatial tasks. And, you know, it's a clock drawing, but it's also like a 3-dimensional box or something along those lines. And then there are other things too. There's language-based tasks. Can you name all the words that you can think of that start with the letter S in 1 minute? Okay, ready, set, go, that kind of thing. Then we showed them some pictures of some animals that aren't terribly common, like maybe a hippopotamus or a giraffe or something. Can you name these animals?
Okay.
So it kind of looks across different cognitive domains, because when we're thinking about cognition, there's memory, of course, but there's also language and visual spatial skills and something called executive functioning, which is like reasoning, judgment, problem solving. And then there's behavior. That's actually kind of the 5th variable. So you want a tool that can kind of look across different things and kind of get a sense of how the person's doing. So I think that's a really good screening test.
Awesome. So we have like 7 minutes left. I have a couple of questions, but I just want to say that I want to give a reminder for our next patient education seminar, which is August 26th. How do I choose a therapist? So we'll have several people here to talk about how we do that. And then I want to give both of you a chance to say how, if a patient wants to see you, how do they find you? Because you're at Pacific Neuroscience Institute and you're at SJPP. So how would patients find you if they wanted to see you?
Oh, thanks. Yeah, so St. John's Physician Partners, and then the subgroup within that is Santa Monica Family Physicians. And I'm Daina Danovitch, so yeah, they can look that up.
And I'm at Pacific Neuroscience Institute, specifically Pacific Brain Health Center, which is at 1301 20th Street. They just call the center, they ask for Dr. Porter. I do sometimes want to see records from like a primary doctor, get some basic information to make sure I can serve them best and that I'm the appropriate person for them, because we have different doctors who do different things in our center. But that's essentially how they access me.
Good. And if anyone can't find those, our navigators here are always available, and we'll get you in touch with either Dr. Danovitch or Dr. Porter if you need that. So, one of the last questions. Oh no, that one's good. Is the number one thing to prevent dementia? I feel like you guys both said exercise.
Exercise is a big one. It really is, because it does so many different things for your body. It reduces stress. It helps with your cardiovascular health. It helps with your overall fitness and well-being. It keeps weight down. It does a variety of different things. It also helps modulate cortisol, which is your stress hormone. So it helps in a variety of ways. So if you had to sort of put your money on one thing, that 150 minutes of moderately aerobic exercise plus maybe a little strength training per week, that would be a really good target. You know, if that
Does weight impact dementia, or that's just part of keeping the heart healthy, which keeps the brain healthy?
Yeah, it's mainly part of cardiovascular overall health, but you know, being higher in weight increases for sleep apnea and other medical concerns and conditions.
Okay.
So these things often sort of track in packs, in a sense. So you want to be kind of normal weight, normal blood pressure, normal cholesterol. You know, the theme is being in the normal range across these different factors.
So I'm going to ask you the same question, but I also want to ask you, since you're primary care, what percentage of patients who come into you are concerned about dementia? Ish.
That voice it?
Yeah, I'm curious.
I would say, well, I have
You have 20-year-olds.
I have 20-year-olds, but then I also have a lot of geriatric patients as well. So, you know, of those who don't have it, I mean, honestly, everyone over 65. I mean, people fear disability more than death, right?
Yeah, absolutely.
And so I think patients are very engaged around wanting to do everything that they can to prevent it. You know, people are entering retirement and are like, you know, finally have some time sometimes to focus on their health, and they're like, tell me everything I got to do.
So do you give them the list of 15 things, or do you give them 3 things?
There really isn't 15 that are evidence-based. So it is kind of the things that we talked about. It's exciting when people are thinking preventatively earlier, because really, you know, starting, you know, preventing obesity, being a mover from early on, it's a lot easier if you've built great habits, if you've learned to cook healthy when you were younger, and that feels comfortable, that's your comfort zone.
Yeah, absolutely.
That's going to carry you, right? So, but even when people start to decide, they have to, if they can quit smoking, if they can cut back their drinking, they can get comfortable with moving, sleeping, eating healthy, like, the basics really translates into better brain health. And of course, and I think the social connections are really, really important too. A lot of times people, you know, are at different stages in life, may have lost a partner, kids might have moved away.
Right.
And I think it's important for people to be thinking ahead about building social networks, for their brain health, for their spirit, for their, you know, and for their support systems that they're going to need, because we're all going to go through different stuff. You know, you can't prevent everything forever. So
no, I mean, unfortunately, but we want to prevent it for as long as we can, right?
Yeah, so try to keep moving, build your, you know, enjoy life, but, you know, go easy on your brain.
Well, I really appreciate both of you giving us this time. This will be edited and posted probably within a week-ish on our Women's Health and Wellness Institute YouTube channel, so please feel free to share it. But we appreciate you guys being here too, and your engagement, and we'll see you August 26th. All right, take care.